Good evening, everyone, and thank you for joining tonight's Woo You event. Tonight, we have a really cool event planned where we get to talk about one of the most talked about topics in eye care, which is the pharmacological management of presbyopia. And we have two of the residents experts on all things pharmacological presbyopia treatments. We have Dr. Nathan Lighthizer and Dr. Gina Wesley. So we're really excited to have them tonight, and we're just going to go through some of the most commonly asked questions. I'm going to help ask some of those questions, and then we get to hear from our experts. So I'll be your moderator tonight. My name is Dr. Ariel Sorenzi, and a big thank you to Orisis for exhibiting at this event, who we'll also get to hear from at the end of this presentation, and we can ask drug-specific questions during that time. For your CE certificate, please fill out the survey. The link will be posted in the chat, and then it'll also be emailed to you once the webinar concludes. Be sure to attend for a minimum of 50 minutes to get your 1 hour of CE credit. Those CE certificates will be emailed to you after this webinar and sent to ARBO with your OE tracker number. Just allow 4 weeks or less for those certificates to be emailed to you. We will have a QR code at the end of the event, and you can scan that with your OE tracker app. If you want to ask some more questions, you can ask it in the Q&A section there. You can find that on the right-hand side of the page. And if you want to minimize it, you can just press that down arrow. And if you want to get it back up, just press the chat, that little chat button. So I will introduce Dr. Nate Lighthizer, though both of these folks probably don't need much of an introduction. So Dr. Lighthizer is a 2009 graduate of Pacific University College of Optometry. He completed a residency in family practice optometry with an emphasis in ocular disease and surgical and laser procedures through the NSU Oklahoma College of Optometry. Dr. Lighthizer has since joined the faculty at the Oklahoma College of Optometry and has served as the chief of specialty eye care clinics, the chief of electrodiagnostics clinic, director of continuing education, and head of the dry eye clinic. In June 2024, he was named as the dean of the Oklahoma College of Optometry. Dr. Lighthizer lectures nationally on numerous topics, most notably advanced ophthalmic procedures, electrodiagnostics, and ocular disease. Here are his financial disclosures. And then Dr. Gina Wesley earned both her doctorate of optometry and master of science in vision science at Ohio State University, the Ohio State University. Her academic achievements were recognized with several honors, including the Graduate of the Year Award from the Ohio State University. I just love the. She's also a fellow of the American Academy of Optometry and was named Minnesota's Young Optometrist of the Year. She is the founder of Complete Eye Care in Medina, Minnesota, where she has practiced since opening the clinic in 2008. Her professional interests span the full scope of primary eye care with a particular interest in contact lenses, dry eye, aesthetics, ortho-K, advanced eyewear education, and practice management. She's a respected voice in the field and a frequent lecturer, advisor, and published author in the areas of dry eye, anterior segment disease, and optometric business operations. She has also served as the primary investigator in over 40 clinical research studies, including contact lenses, pharmaceuticals, and medical devices. So here are her financial disclosures, all of which have been mitigated. So I'm excited to go ahead and jump on in with some questions if you guys are ready.
Ready. And I think this is going to be an exciting next 50 minutes, Gina. We did our webinar on December 17th, and there were so many questions that there's no slides tonight. This is going to be no slides, just basically a question and answer session. We may know some of the answers. We may not. We may go, we just don't quite have enough experience yet. I may do it a little different than Gina. She may do it different than us, but we've got 20 to 25 kind of pre-planned questions that we will discuss, but we want to hear from your guys' questions as well. Don't you think, Gina?
Yeah, no, I think the most important thing is that we want to be able to give you practical advice, realistic expectations, tools to be able to help you navigate, explore, and be successful with the presbyopia, drops in market that's out there, because there is a tremendous opportunity. And I think that is something that hopefully becomes easy to understand as we move through all of those questions tonight.
And wouldn't you agree that we're still learning about this? We're still relatively in the infancy of pharmacologic management of presbyopia. Would you agree?
Yeah, no, I would say even since we presented in December, there's a few tips and tricks that I have that are new that I didn't even think of or wasn't really aware of at that time, because it is ever evolving. And we'll be talking about that, I think, tonight with some of those questions. So I think it should be interesting.
Yep.
Awesome. Well, let's go ahead and start with you, Dr. Wesley. How are you currently positioning presbyopia drops within your overall presbyopia management strategy compared to, presenting glasses, contact lenses, or even surgical options to patients?
It's interesting. As I was preparing for this presentation tonight, I saw patients today in my clinic, and there were many of them that I was talking about presbyopia, pharmacologics as an option for them. And so what I've done to help grow this area, create awareness, because I do think that is something I've realized, is that people might be a little cautious, but when you talk about it, and every time that you're in your practice and you're mentioning all of the different options, I'm just weaving it in as here are the things you could consider doing. And by the way, there's also these drops that you could take that help to modulate your pupil, and they enhance your near vision. And it's an option in the many tools that we utilize to help enhance your vision that may be something that you benefit from, whether that's all the time or some of the time. Just understanding that that's out there is something I want my patients to hear, because I don't want them to hear about it from someone else or discover it and be like, gosh, I wonder why Dr. Wesley didn't mention it. So I've just started weaving that into the conversation with my patients, and kind of being able to feel from there how they navigate that. Of course, selecting patients who I think are appropriate for these products.
Yeah, Gina, that's so much of our job in whatever we do, whether it's, I wasn't in clinic today. I was in because I was at the Capitol, but I was at the clinic yesterday and the day before, and I had a number of laser procedures and patients with floaters. And it's my job to explain all of the potential options that we could treat their floaters with, whether it's observation or laser or floater only vitrectomy. Same thing in the presbyopia space. It's our job to cover all of these different options. And we have so many tools in the toolbox. I love a couple of things you said, the tools, cover all the different tools in the toolbox. And, if you ask yourself, the 900 docs that we have on this call, do you want your patient to hear about all of the options, or at least a couple of the options from somebody else that mentioned? So I think we don't want them we want them to find out from us that we're on the cutting edge, that we bring the latest and greatest information to our patients. So it's another tool in the toolbox, and you cover all of the options and the pros and cons of each.
Absolutely.
So say that you're presenting these options to patients and you go through the full gamut of, we can prescribe you a progressive multifocal contacts, or these, presbyopic drops. How does it change your treatment strategy on, say, a multifocal contact or their progressive glasses if they're also going to be using a presbyopia drop?
Nate, I'll let you take it from here, and I'll tell you what I do once I hear you share your perspective there.
So I think it all depends on the patient and their expectations and their visual demands and what they're currently wearing and what they, expect out of this. I had a 47-year-old in yesterday for a refractive surgery evaluation, and he was interested in LASIK or PRK. But, it's a little bit different when you're talking with a 47-year-old for refractive surgery versus a 27-year-old. By the way, he's a minus 250. He's a minus 250. Gina, what do you're kind of going, minus 250, 47-year-old? Do you really want to make him plano sphere and now he's super? So my point is that's, again, in a different space, refractive surgery, but all of these patients are a little bit different, nuanced. Some of these are ideal patients that maybe have never had glasses and never had contact lenses and are entering their 43, 44, 45, 46, trying to stay out of glasses and contacts, versus your patients that have multifocal contact lenses. They wear them all day, and they may have different expectations or demands. So I think it just depends on the patient and what they're telling you, what they would like to achieve with this. I'm interested in getting to this point. Well, whatever that is, then we can discuss our options. Gina?
Yeah, so I think one of the best perspectives I've had since we last did this presentation is that this really can fit in for people in various ways. And a lot of it is an enhancement, right? So it can be a standalone depending on the patient, but it also can be an enhancement for somebody who's like, well, most of the time, and I know we've all heard this, my multifocal contact lenses work pretty well, but when I'm in a dimly lit restaurant and it doesn't work as well, right? So I think to those patients, I'm like, maybe, you would be a great candidate to be able to, put in one of these drops prior to you going out. You're putting in your multifocal contact lenses and you're going out to dinner. Maybe that would give you what you need to be able to see that menu a little more comfortably and still be able to converse with your people that you're at dinner, things like that. So I'm starting to think about situational sort of experiences for our patients in knowing that this could be a fit for them in a variety of ways. It doesn't have to be an all the time. And I think that's what our patients sometimes think. They have to choose one option. They have to choose one, maybe two things that help enhance their vision. And we have to educate them that it doesn't have to be like that. Like, we have a lot of options. And one of my favorite phrases I say to patients is, you can choose none of these options, all of them, and some of them, and it's the right answer. It is the right answer because it's what works for you. So having that dialogue, and just like anything new, as I mentioned before, it's kind of a grassroots effort where you mention it. No, Nate, if you came in and you were my patient and I told you about this option this year, you might be like, I've never heard of this. It's strange. Maybe you don't pursue it, but you start to maybe hear a little bit more about it. You think about it. And then maybe the next time I see you, you're like, hey, remember when we talked about that? That sounds like something I would like to try. That sounds like a great option. And as we all know, it's not hard for us to be able to get these products to these patients now for them to be able to use.
It makes you appear so smart and intelligent and on the cutting edge to the patient, even if they decline at that visit. As you just said, present them all the options. I use the tool in the toolbox. Mr. Jones, Mrs. Jones, somebody that's very handy and fix it, whether it's you or somebody else. They don't use the same tool in different situations. They may have to use this tool in this situation and a different tool in this situation, and we're going to do the same thing with your multifocal contact lenses or your progressive edition lenses or your presbyopia drop. We have different ways to tackle different scenarios.
So kind of a follow-up question that came in is specifically with the multifocal contacts, kind of using them as maybe an enhancer in those situations that you discussed, Dr. Wesley. Do you notice a change in the way that they're able to utilize some of the optics of the multifocal when their pupil is smaller, like, maybe a center near or a center distance design might behave a little bit different? Have you had much experience with that yet?
Yeah, no, I think because most of the designs out there are more center near based. And as I tell patients, our natural pupil reaction when we're looking at something close is to become smaller to increase our depth of focus. So by using these drops, we're just enhancing that, right? And we're enhancing how that pupil is now looking through the optics of that lens. Like any multifocal lens, right? We know that the optics of each one of our eyes is different. And even if you have the same prescription, it might work well for one patient versus another. So I approached the dialogue just as I would with a multifocal contact lens. And I said, let's try this. See, because in theory it could help you, but we won't know because the way that your eye is structured and the way you use your eye and the things you're looking at with your eyes in your day-to-day may be different than someone else, and it may or may not work, but we won't know until we give it a shot, right? So I instruct them, with the the on-label recommendations of instilling the drop. I find sometimes one drop is all they need to be able to enhance that for the period of time that they're looking to utilize it. But it has been a really nice way to help enhance what is already in hand for patients with their eyes and their vision, to give them a boost. And so that worked out well for me here with those drops here over these last many months and year that it's been available to us.
Great. Do you have anything to add, Dr. Lighthizer?
I think she covered it beautifully. Okay,
great. Well, this one's for you, Dr. Lighthizer. With Patients that are suffering from dry eye, do you find that sometimes these drops can be irritating? Are they preservative free?
Anytime we put anything on an irritated ocular surface, it has the potential to irritate that further. But I think that's why, you look at options and you look at the formulation. Is there preservatives in it? Is there preservative free? What's the pH and things like that? Formulation matters. And I want something, especially in a dry eye patient, that's as gentle to the ocular surface as possible. I mean, we battle this in glaucoma all the time. If we need to lower the pressure, and it's a double-edged sword. We can put a drop that lowers the pressure, but is it exacerbating the dry eye? We can put a drop in that's going to have that miotic pinhole effect, but is it exacerbating the dry eye as well? So I think, you balance all of those different things. And I'll talk to patients about that, when you put this in, there could be some burning and stinging and a little bit potential headache as well. You go through the potential adverse events. You also have dry eye, Mrs. Jones, and anytime we put a drop in the eye, that potentially could exacerbate. But that's why I'm choosing this option that's preservative free, or this option that's formulated in such a way that I think it's going to help with that near vision while not sacrificing your ocular surface.
Great. And then speaking of, concurrent potential, complications, are there specific retina pathologies that would maybe prevent you from prescribing a miotic, and how would you screen for these in your practice? I'll have you take that one, Dr. Wesley.
Yeah, no. So I'm being very careful with the moderate to high myopes, right? We know that structure, their eye is elongated. You start involving potential complications with tugging and pulling on that retina, and you could potentially have some issues and problems, which is something we discovered in some of the earlier days of products that were on the market first off. Now, the interesting thing that has come about over the last many months, and this is new since we did our presentation in December, is there's been some data that's come to light that's actually very, helpful in helping put my mind at ease. I know, Nate, I want you to talk about that because you do a great summary on this as I've been chatting with you.
Yeah, like I said, there's been a couple of things. We'll go through both of them of new things since December 17th when we last did our webinar. One of them, a study out of Baskin Palmer that looked at some miotics. It looked at pilocarpine 2%, which is obviously not in the presbyopia space, that's in the glaucoma space, but a pilocarpine with higher concentration, pilocarpine 2%. And then it looked at pilocarpine 0.4%, which is our lowest concentration of pilocarpine approved for presbyopia management. And then it looked at sterile saline. And it said, let's image the ciliary body, that ciliary muscle, and see the movement in it, the shift in that, as well as lens thickness. And obviously, we'll look at pupil diameter as well. So it looked at a variety of different things. But its main thing it wanted to look at was what's the effect on the ciliary muscle, that ciliary body, and movement of that? Because we all know the movement of it. It's not the pupil coming down. It's not the miotic effect that's going to lead to retinal tears or retinal detachments. It's the pulling and the movement of that ciliary muscle. So we would love to be able to get the miotic effect with minimal effect on that ciliary muscle, that ciliary body as well. So they took like 45,000 OCT images in these subjects, and it was a smaller study, but it looked at 10 subjects, and they were on pilocarpine 2%, pilocarpine 0.4%, and again, the saline. And what they found was pilocarpine 2%, no shocker, it moved the ciliary muscle. It moved that. You could see that movement that we can expect, and that's why there's a rare risk of retinal pathology. Pilocarpine 0.4% and the saline, there was no statistical significant difference between the two. Those two were different than pilocarpine 2%. So it really shows, Gina, concentration matters, doesn't it? Dosage matters. As we take the concentration from 2% down to those lower concentrations like 0.4%, not seeing the effect on that ciliary muscle. And that puts my mind, at least it puts it at ease that we are much less likely to affect that retina stuff.
No, and I think like I tell my patients, and you know, because people may have had a prior experience with one of the stronger, you know, pilo concentrating drops that are out there and not maybe had the best experience. I'm like, just to your point, Nate, concentration matters, but also the delivery, right? The dual lubrication, making sure that you've got a near neutral pH. This matters for absorption because you then don't need the high concentration to have the effect that's still effective, but then you have the safety profile that you feel more comfortable with. So it's gentle yet effective, the way I describe to patients now, if there's any concern. And I do think, you know, general patients don't necessarily know or understand, but I do think this is important as I've talked to other doctors. You know, we, Nate, have taken the time to really research and get our hands on this. And we just want to be able to share that information with everyone so that everybody can feel more comfortable about how we use these drops. And we're always concerned, right? We never want to put something in someone's eye that can cause a potential complication and issue. And so it's nice as these products have been out and we can find out more of this information, very helpful to know that things are going to likely be very okay when we're using these with our patients.
And put my mind at ease. And all of the subjects in the study were dosed all three pilocarpine 2%. So it's not like, oh, they just got some of the subjects and you just got lucky and they didn't have to move. No, it was all subjects got all of the pilocarpine 2%, pilocarpine 0.4%, and the saline. And again, pilocarpine 0.4% was equivalent to saline with no movement of the ciliary muscle. So that's a big deal. And that should put our mind at ease.
It's funny that you mentioned the pilocarpine 2% because right before you did, a question came in about pilo 2% and practicing back when that was, you know, prescribed to patients. And now this particular doctor said, I'm kind of hesitant to prescribe the new and obviously lower percentage with fear that some of my patients will have some of the side effects like headaches. So would you say that that's not the case with this lower percentage because of that lesser effect of the ciliary body?
No,
much less likely.
Yeah, you're going to have a lesser effect. You may still have some of those headaches. I think it's important to tell patients and realistically set expectations because people do respond differently. But I find over time, that dissipates. It seems to be kind of an initial effect, and then that does get much better as time goes on. There is definite neural adaptation. And it just like, again, there's a lot of parallels for me in the conversations I have regarding these medications and my multifocal contact lens wearers, where we discuss, hey, don't worry at first if it seems a little strange, right? Your brain is getting used to this new sort of vision. So you got to give it time so that you really can tell how this is working for you. And so that usually involves a conversation about making sure that you're using these drops and trying them for, you know, a good week to 2 weeks to be able to really assess how that affects and helps them in their day to day. And so those are other helpful conversations I have with my patients to ensure success. And again, the more you educate your patients about like, here's what may happen, here's what may not, it does really help you to find the highly motivated patient, which is the patient who's going to succeed. Mm-hmm. You know, we want people to be able to have good success. We don't want patients who are just, you know, kind of, apathetic about it. And it helps when you talk about what to expect so that they know and they can weed themselves out or in as to whether this is going to be something they're willing to work with.
And I like to list percentages as well, you know, just very quickly to patients. You know, you may have some headache. It's going to be much less likely, as Gina said, than your pilocarpine 4% or 2% or things like that. But I tell them, you know, if we use the lowest effective concentration that we have, you know, it's about 6%, you know, so you may get a little brow ache. It may ache just a little bit, but it's only about 1 in 20 patients. So it may be you, but likely it's not. But get out in front of it.
Mm-hmm. Do you sample these drops for patients to be able to trial before filling a prescription?
Yeah, so there's some great programs now for us to be able to give patients these drops and prescribe at the same time. So they're able to utilize them, get them rolling, but at the same time be able to get that prescription filled quickly. So it's efficient. That's the way I like to think about it in my practice. You know, Nate comes in, I'm like, Nate, you're interested. I've got some drops for you to be able to start using right away. I'm going to prescribe it so that you can get this mailed to you so you can continue on with it help with that adaptation like we had just talked about. So it's pretty streamlined and easy and straightforward for me as I'm working with these.
And I think it's important for, for the docs out there to hear that, as Gina said, there's an adaptation period to this. There's also an adaptation to their new vision. You don't want them to just try this for, I tried it once and I didn't have crystal clear vision. I want you on this for a minimum of a week. 2 weeks would be better, so you can kind of get used to your new near vision and your new vision as the pupil gets smaller and we enhance that depth of field, that depth of focus. There's literature out there that shows a week later, there's a higher percentage of patients that are gaining more lines of vision with the exact same pupil size. So their pupil size was this right away, and 70% were getting improved vision 3 or 4 lines, and a week later it's 80 to 85%. So we get used to that new pupil size, and the brain, as it interprets that new pupil size and that enhanced depth of field, depth of focus. Clinically, Gina, to me, don't give up on this after a day, after a dose. Like, Mrs. Jones, Mr. Jones, I'm going to want you to take this for a week or 2 to get used to this, and then we can kind of spot use it after that. But, let's use this for a week or 2. It's kind of what I educate patients. Gina, what do you do different?
No, so I think that's great. It was interesting because as I worked and I was able to see clinical data on the Closey product prior to it coming out, I remember looking at that data and going, there must be an adaptation because nothing else has changed. The pupil size was very consistent as far as how small it was. It was a very, very close range. I was like, nothing is changing here but their ability to achieve. And so that data really has been now proven in real life as I work with my patients. And as we mentioned at the beginning, I have the opportunity to run a lot of clinical studies. And I find that in the studies too, the longer it's nice. In a study, I get to tell people exactly what they have to do. They have to follow my instructions. And we would see that things got better the more they used the product. And it didn't take very long, but that lead in and that adaptation did matter for them to really truly understand how that product was working for them.
And another question was, say that you have somebody in your chair and you just think, oh my gosh, this person is a slam dunk for some of these presbyopic job options that we have. What does that patient look like to you, Dr. Lighthizer?
To me, it looks like me in a couple of years. I just turned 44 this past weekend. I am a planosphere, have been my entire life. No LASIK, no refractive surgery. I've never worn contact lenses. I've never worn glasses. I have no interest of putting contact lenses in my eyes at all, and I have no interest of worrying about putting glasses on my face. Yeah. So as I lose my near vision, or start to lose it, number one, it's not going to happen to me, guys. I know it. I still can see up. It's not, right, Gina?
Nope. Okay. You're going to be the exception to the rule.
That's right. But, when I get to be 45, 46, 47, and gall darn it, I can't see as well up close, I think I'm one of the ideal patients because I've never had glasses and never had contact lenses, and I'm motivated to stay out of them. So I think, I'm kind of the picture of the perfectly ideal patient. Gina, what do you think?
No, I 100% agree. You'd be sitting in my chair. I'd be like, well, because you, of course, would not be appreciative of the fact that you've never had to do anything your whole life. And you'd be extremely frustrated as to that this is happening to you now. And so I'd have to counsel you and make sure that you feel good about it. But I would certainly mention this, especially because you would be motivated to be free from any vision correction. I would also be a good candidate because I'm a very mild myope, right? I'm currently wearing multifocal contact lenses, but I'd like to be able to have opportunities to not have to wear these, or maybe to enhance my vision. Maybe I'm going to be golfing. Maybe I'm going to do something where I'd rather have, my spherical lenses in. And so it's those mild to moderate prescriptions. You want your kind of presbyope, right? Mild to moderate, motivated person. That's the person that I'm seeing. Post LASIK patients are highly motivated as well. Very important to ask those post LASIK patients, Do you, especially if they weren't your patient prior to them having had LASIK, do you remember what your pre-LASIK prescription was to help guide you to make sure that we're not targeting people who are maybe very, nearsighted, myopic? So those are the patients that I'm looking at as good and ideal candidates.
Great. And if you had to pick who would be better, a hyperope or a myope, what would you pick?
Ooh, that's a tough one. I will say this, hyperope may have some distance vision improvement because their latency is making it. This happened to actually one of my friends. So one of my friends, we discovered after the fact, long story, I had an eye exam on him, but he had a lot of latency in his prescription, which we didn't discover until later. And I was like, that's why that drop works so well for you. Because he was like, God, my near vision's really good, but my distance vision's also really good. And I was like, I thought you were like a plus 75. Sure enough, next time I checked him, he was more like a plus 2. And so he had some additional benefits. Now, that is anecdotal. That has not been shown in the studies, right? We see a non-reduction in distance vision in the studies. But I think those are the most grateful patients because they don't even understand how much they're suffering they're like, I can see, right? But they're working harder than they have to. But I think myopes naturally have an extended depth of focus. So I feel like their visuals are a little more flexible. And so just like with multifocal contact lenses, I feel like I do have really good success with my myopes. Hyperopes, it's because you're helping correct distance and near that I feel that you're successful. So it's kind of the same. So I keep coming back to this with like multifocal contact lenses, but I do think there's a lot of parallels. So those are my own anecdotal observations. Studies have shown that both parties, I think, do very well, which is nice to know, right? And it always depends on the person.
And I think that's exactly why we both kind of went, it could kind of go either way on this one, depending on how you look at it. If you made me pick, I would have went slight lean towards the hyperopes for the reason that Gina outlined there. But, you could go either way in that. So, yeah.
Well, let's shift a little bit to some practice management questions. We have quite a few. So say that you prescribe one of these drops. Are you going to have them come in for a follow-up? And if so, how would you bill for that?
So Gina, I'm in academia, so I'm clearly the expert in all things practice management here. So I'm going to kick this to you. How's that?
So I only have them follow back up if I'm concerned that maybe there's some sort of complication issue or this patient needs hand holding because we're exploring and navigating many options. Otherwise, I don't have them back. We talk, and like I said, I educate my patients about the expectations. I've already picked them because I think they're ideal candidates and I don't think there's risk, but I'm still telling them about the things that they need to be aware of for risk so they can come back and see me if there's complications. I've usually done a dilated exam. I've got great retinal imaging, making sure everything is healthy prior to starting them. So, but if I do bring them back, I bill it medically, right? Because we're using a pharmacological product to enhance or change. It's no different than prescribing any other medication that you're using to get some sort of result. There's complications and things that need to be monitored. So if I do bring them back, I bill like an office visit.
Okay, perfect. Well, you guys answered several of those questions with that response. Thank you. Can you talk a little bit about the presbyopia drops that we have available to us? And just give us kind of like a little bit of a description on our options.
Well, and I think that is the second kind of exciting thing. We talked about the effect on the ciliary muscle, that study at Baskin Palmer that's come out since we talked on December 17th. Very exciting. As we discussed, the other one is we now have 4 FDA approved drops for presbyopia with the approval of Uvezi. And Uvezi is the combination of carbachol and brimonidine. So I'll quickly kind of go through in order of FDA approval our options. Our first one back in 2021 was pilocarpine 1.25%. You guys know it as Vuity. So that's pilocarpine 1.25%. Then second one that was approved was pilocarpine 0.4%, which is known as Closey. So that's our lowest concentration of pilocarpine at 0.4%. So that was Closey. The third one was known as Viz. That's aceclidine, 1.44%. And then again, the most recent one is Uvezi, a combination of carbachol at 2.75% in combination with brimonidine, 0.1%. So it is the first combination dose drop, meaning two different molecules or drugs in the drop with Uvezi. That is preservative-free. Closey is preservative-free as well. So those are your four drops: Vuity and Closey and Viz and Uvezi. So, Gina, it's a variety we have four options now. So, and I think that really shows that this is not going away. And we're getting more tools in our pharmacologic toolbox for presbyopia. So now we're going to be faced with decisions on which one you go into, this one or that one or that one or that one. Your thoughts?
So I have a question right back at you. Something that makes me a little concerned about Uvezi is the brimonidine component and potential allergies. Did that thought cross your mind at all? That's just something that I'm thinking out loud here as I'm looking. So I'd be very interested to see. I have not seen any study data yet. 10 point, please reach out. I'd love to hear some information about potential allergic reactions. I think we've all, if you manage any amount of glaucoma, have had patients that have had that issue. However, the brimonidine does help, right, with the potential lasting pupil, meiosis with minimal effect. So dosing, I think, would be interesting, but I haven't gotten my hands on it and I haven't seen a lot of data. So I'm interested to hear more when that comes out. But yeah, no, I mean, it's nice to be able to have options. I tend not to use Vuity simply because it is a stronger concentration of pilo, and we have a very effective low dose pilo option with Closey. And Closey is probably my go-to at this point in time just because of its gentle effectiveness, which is my key phrase I give patients. I have utilized Viz as well. That place for patients too. It's still something I'm trying to navigate as to who is a better fit. I don't know. I mean, what are your perspectives at the school, Nate? Because I bet you guys have a lot more exposure and opportunity than I do at my practice. I don't see near as many patients as you guys do.
Yeah. So it's important to remember that all four of these are working on the pupil, whether it's pilocarpine, whether it's aceclidine, whether it's carbachol and brimonidine, they're all working on the pupil at that pinhole effect. We're not restoring accommodation here or anything like that. So they're all working on that pinhole effect from meiosis. Let's talk on Uvezi a little bit. Carbachol, that's going to cause meiosis. It's going to shrink the pupil. At the same time, brimonidine is going to inhibit the iris dilator. So it's also going to, again, work on that pupil, and they're going to probably have less redness with the brimonidine in there as well. And that showed that in the study. So combination drop, it's not even available yet. So we haven't used Uvezi yet. So to be determined on that. Our two main ones have been over the last couple of years, or I should say last 6 months, have been Closey and Viz. I agree completely with you, Gina, that, when you've got pilocarpine 0.4%, that means a lot to me, that lowest effective concentration of that, and the formulation, that matters, preservative-free, again, all that stuff, it matters. So I don't prescribe Vuity anymore. I did it early on in the experience when that was the only one we have, but I don't anymore. We've had multiple questions on Closey versus Viz. The literature, the FDA approved studies probably lean, I always have a teeter-totter when it comes to glaucoma, Gina. You want effectiveness with minimal side effects, right? And it's a balance. And if this is effective over here and this is tolerability over here, you want the appropriate balance. I think for Closey, it's going to have a nice balance, and it's definitely going to have a nice tolerability at that 0.4% with the formulation that it has, and effectiveness may lean slightly more towards Viz. So, tolerability, maybe a slight lean towards Closey. Effectiveness, maybe Viz lasts a little bit longer, 10, 12 hours based on the studies. But, I've had some patients that complain of the redness and the stinging and burning with that. I had one patient, I'm not going to bring up the slide. But it was just funny what they commented here. Let me see if I can find it. I had it in our slides here. Burns like hell, red as hell, a little bit of a headache, but I could see the hairs on my forearm at 3 inches. Was this early 50-year-old patient that was on Viz. So, man, I can see the hairs on my arm at 3 inches, but yeah, my eyes are a little bit red and it's burning just a little bit as well. So that's a long-winded answer going in my early clinical experience. If a patient says, Dr. Nate, I want the best efficacy, like I'm willing to tolerate any side effects, and I want the best effect, longest effect, I might slightly lean towards Viz. If they want the balance of efficacy and tolerability, I probably would lean towards Closey. That's my long-winded answer. So, but you got to use it yourself, and depends on the patient.
Yes. And I think you can try both and see what's the better fit. I think there's a lot of data out there that we have, learned about pupil size and what's the ideal pupil size. And I find that sometimes too much is too much, and that pupil size, although you can see your hairs on your forearm at 3 inches, you feel like you're in a dimly lit room or not, right? Depends on the patient. Like, what's their starting pupil size? What, do they have? I live in Minnesota. We have Scandinavian patients. I have a lot of blue-eyed patients where pupil size matters, right? And the impact any one of these drops have on them is something cosmetically their family notices, their friends notice, like what's going on. And so again, I'll oftentimes tell patients, you have to try these drops, but make sure you try them at home. And you don't have to go anywhere for a little while, because you don't know how it's going to impact you. And I want you to be safe and feel comfortable for whatever activity you're going to be doing. So just an FYI, that would be my recommendation. And when you have a better idea of how this works for you, then go ahead and use, as you would like to. But I think it's important, again, all about expectations, because people do respond. I know there's study data that shows that the average person had this much pupil, effect. And it's very, obviously, the numbers are important. Safety and efficacy are important. Mm-hmm. But the reality is that my patients sometimes aren't very good about getting drops in. They either get a little too much or not enough, and they might get a difference between the two eyes. And so life happens. And so those are the constraints that we have to deal with, which are giant constraints, really, that help us to know. And so giving patients the options, and that's the wonderful thing. We have options, which is really exciting.
Yep.
So
Gina, I'm going to put you on the spot then. Agree or disagree? Efficacy slightly better with Viz, tolerability slightly better with Closey, or do you disagree with that?
No, I would agree with that. I think with Viz, it works. But the pupil size thing is a real issue for my patients that I've had it. Some people don't mind it, but some people really notice some dimming effect. I have patients tell me, they're seeing really well, but they're like, something's weird, like something's off, and they can't quite put their finger on it, but it works, right? So again, try it, adapt to it, see what happens, give that, just like I'll give contact lens, multifocal lenses, try this brand for a week, then try this brand for a week, see what you think, right? They all work differently, and they work obviously dependent on what you're doing with your eyes at that time. So you just have to really give it a try, more than one day for sure, to really know.
And more than one patient as well. You can't make any judgments on one patient. You need to get 5, 10, 15 patients on these to get a reasonable sample to get some experience, because it may go not well in one, and the next patient comes in going, man, this is amazing, doc. So get a larger N number under your belt.
So for the pupil size, is there a minimum pupil size that you would think to maybe would it be a good idea? And then how are you measuring that pupil size?
So I try to look at them in like, your exam room lighting, right? So it's not bright, but it's not, super dim or dark. And I'm just trying to gauge and look. Obviously, my patients, if they have brown eyes, I am doing more of a slit lamp, kind of just trying to take a peek and see indirectly where their pupils are at. If they already have really small pupils, if they're older, I know already that this might not be something that works for them. If they've got cataracts, that's also something I'm thinking about, because I'm like, well, yeah, we might be helping enhance depth of focus, but now by limiting, there's some different factors there. We know that the ideal pupil size is about 2 to 3 millimeters for that good, depth perception without there being a lot of dimming. So as I'm looking at them, I'm like, gosh, are they around, at least 4 or 5 and kind of that dimmer, like mesopic setting in their room lighting? This might be something that works for them. But even if they're not, it still doesn't mean they're not a bad candidate for it, again, because they just need to try. But I try to stay away from the really small pupils, because I just know those are already the people that have a natural enhanced depth of focus, right? So those are the people that I try to probably stay away from.
I was going to say less than 3 millimeters is kind of if their natural pupils are less than 3 millimeters, that's going to be, they're already starting small. So that's going to be difficult. You're going to hear there's different philosophies and different camps on this of where that we want that pupil to be, somewhere between 1.5 and 2.5 millimeters. I kind of like the 2 to 2.5 millimeters sweet spot, as Gina was mentioning. But again, it's going to depend on each individual patient. And that's why you want to get some multiple patients under your belt with each of the products.
Mm-hmm. And what about pseudophakic patients? Any experience with those?
I have not prescribed this for any pseudofakes at this point in time, so I can't speak to that.
And I've only done it in one at this point, and that was with, some post-cataract surgery, some glare and, kind of nighttime issues and halos and things like that, which it helped with. So not much experience at this point, but I think in the right patient, it could potentially help with some of those glare and halos and, aberrations that they're seeing. Obviously, when they've had cataract surgery, they've lost all of their ability to focus, depending on what type of IOL is implanted. So there's a lot of variables that are involved post cataract surgery. But I don't think it's an absolute contraindication in that patient. It depends on what their goals are and what we're trying to accomplish.
And same question you would ask your your LASIK patient. Do you know what your prescription was prior to cataract surgery? If you as the doctor don't know, they come to you as a new patient. Very important probing questions to ask.
Gina, do you do a dilated exam or an ultra wide field photo before every patient when you're considering putting them on one of these medications? We do.
Yes,
I wanted to see if yes.
Yep. Mm-hmm.
To me, that's really a must. You need to examine the peripheral retina just to make sure we have no, major contraindications, what their prescription is before we prescribe even these very low concentration drops, which again have shown minimal to no effect on the ciliary body now via our most recent studies. I think it's still prudent and wise to examine the peripheral retina.
Yeah, and we have that data about Pilo, but we don't have that data about carbachol. We don't have that data about aceclidine, right? So I think it'll be really interesting as we move forward, as more of that comes out, it just helps us to understand a bit more about the potential risk profile.
Mm-hmm. So tell us a little bit about when you actually prescribe these options. Are they having to go to a specialty pharmacy? Or is there any insurance coverage? What do you kind of counsel patients in terms of price expectations?
Yeah, so we go through one of the specialty pharmacies is how we usually do that. There is no insurance coverage on this, so I let patients know this is going to be a cash pay thing, that their insurance will not cover that. So that's how we handle that.
Yep, same. I'm like, you're going to be contacted. Be ready for the call. It's pretty easy. It's cash pay. here's what I'm prescribing, and they're going to mail it right to you. So it's pretty straightforward and very easy. No insurance involved.
Mm-hmm. Yeah, sometimes that's better. So, Dr. Wesley, going back to when you said that you would bring the patient back if they were having some potential issues or red flags with the presbyopic drops, there were several questions asking what code would you bill?
Well, I think it depends on their complaint, right? So let's say they had tried the drop and they had some sort of side effect, right? I am now seeing floaters. I have some sort of visual strain, blur in my vision. I'm seeing flashes. I'm really uncomfortable red eyes. So I think it depends on their primary complaint. And then obviously what I'm finding clinically when they come in, but it's going to be a medical diagnosis along those lines with what they're complaining about, and then also what I'm seeing for the diagnoses for that. And then the testing is done appropriately depending on complaint. But I'll be honest, I really haven't had many people coming back with issues or problems. It's been pretty good overall.
Okay, great. And how do you handle your borderline angle patients for monitoring? The question was, do they request they don't take the drops for a specific number of days prior to assessment to ensure proper angle assessment and accurate gonio?
So did you ask about narrow angle patients? Was that what it was?
Yes.
Yep. And there was a question I saw last time from our last webinar as well, is why is there an issue with your narrow angle patients? Aren't these myotics? And they should pull the iris out of the angle. That's true in part, but also remember that the higher concentrations of pylo and those myotics have an effect on that ciliary muscle and can cause a rotation or a movement forward of that, as well as an increase in lens thickness. Your pilocarpine's 2% shows an increase in lens thickness, and that can increase your pupillary block, which can narrow your angle. So yeah, if you think of it one way, it can move the peripheral iris out of the angle, but you have those other mechanisms of why there's caution in narrow angle patients. If you're really evaluating a narrow angle patient and you want a true, what does this look like? I would educate them that I would probably not want them on the drops for a couple of days before, a day before, and that would be totally fine. So I can see what the angle looks like truly without effect on the iris and things like that. So that's how I would handle that.
What he said.
Perfect. And how frequently do you guys have patients that have concerns with nighttime driving and kind of the dimness, potential dimness impact?
It happens, but it's not so bad that it's unworkable, right? It's not like they can't see. It's not like they are struggling. They're just like, this is not, what I'm expecting. And sometimes they don't know how, they're like, something's, like I had said before, something's off with my vision. They can't even really put their finger on it until you say, like, does it seem like it's like dark, right? Do you feel like you need to turn the room lights up, right? And they're like, yes, that's it. And so then you discuss, and then once you obviously talk about what happens to the pupil. So that's been my experience, is that I have not gotten really any nighttime vision driving complaints. But we also talk about that, right? Like, I'm also like, you have to be careful if you're nighttime driving, because it could make it a little bit harder to see. It might not, but maybe if you're going out to dinner and you're using the drops to enhance your vision and you're at all concerned, you have somebody else who's driving if that's a concern. But I go, again, you don't know until you try the drop and you see how it impacts you.
I've had a couple report that. But I think the key here is you need to talk to patients about it, and you need to document that as well. I've been involved in enough litigation cases reviewing records where what we document is so important when the patient comes back, and if things worsen, come back, and signs and symptoms of retinal detachment for other things. And you certainly wouldn't want a patient to get in an accident at night when you prescribed them a medication and they have a litigious attorney that says, well, you were never told about that and you were at risk and we need to sue that doctor. It's highly unlikely, but I would encourage you to educate patients. This is a rare possible side effect, and document that in your your plan of, I educated the patients on this, and this,
Yep. And I just create a care plan item in my chart that has everything.
Yes.
And I can just drag that over because we talked about it and it lists all the things.
Yeah, love those. So we talked about prescription. We've talked about pupil size. How about age? Do you consider age? And what would be the oldest patient that these drops could work on?
Well, I think that goes back to your ideal candidates, that probably, still have a little bit of accommodation left and haven't lost everything. Your patients in their 40s and 50s, I think generally speaking, very generally speaking, are going to be better candidates than your patients that are, in their 60s, 70s, and 80s. But again, that's a generalization. But when I'm factoring in age, I think, if you want to set yourself up for success, I think you're probably a little bit better off in the 45 to 65 year olds than you are the 65 to 85 year olds. That would be my opinion.
Okay, great. And then what kind of paperwork do you provide for patients? Do you have pamphlets in the office? Do you have like a intake form to kind of screen for candidacy?
No, I do have some pamphlets that I can hand patients for more information. So I think that's another good way to educate them, because it does also list out expectations, potential side effects, cautions, and call outs. And then when they get the product homes, there's oftentimes even more information that they get with the delivery of that. So that's really nice as well. I don't have anything in particular in an intake form. The signage alone that I have in my office sparks questions from patients who are interested and about it. But yeah, I feel like it's more on me to identify good candidates at this point in time. But we do have sort of.
Gina, I'm curious. You hang out in the contact lens world much more than I do. How do you handle the potential second drop that might be needed in some patients that are putting in their contact lenses, maybe their multifocal contact lenses? They put the first drop in before, but they need a second drop 2, 3, 4 hours later. How are you handling that in those contact lens patients?
So for many patients, I find when they're doing this enhancement with contact lenses, one drop may be enough. Okay. Which is an ideal situation, obviously, for convenience. Now, I have a lot of daily disposable wearers, and this would definitely be off-label. But I say, if you have to enhance, I was like, let's see how it goes if you instill over top of the lens. However, we may be impacting absorption. We don't want this to impact your lens, right? So it is ideal if you remove to put in that second drop and then put the lens in. And especially if they have a non-daily disposable, I'm 100% saying you have to remove the lens for that second drop. But my hope is that for a lot of people, one drop is enough for them to get the impact that they would like. Because remember, we're looking for an enhancement. We're not looking for the full-blown effect that you would want for somebody like you, Nate, who needs, you're wearing nothing, you're doing nothing, you need all of it. I think that there's a lot of people that really benefit from just the one drop alone. Mm-hmm.
Perfect. Well, thank you guys so much for answering all of these questions. Tons of interest, and I loved this dynamic conversation. It was awesome.
And that's what I think is so fun, because we continue to learn on this. And as you know, none of us have all of the answers, and we continue to just gain more experience and learn on this. And I think that's the fun part of this. And again, I encourage people, get some experience with this, get some experience with all of the products, and see which one works best in your practice for your patients. And it's probably going to be multiple of them in different situations, but get some N numbers under your belt with each of these products.
Mm-hmm. Okay. Fun. Let's just do a fun thing real quick. How many patients do you think that you guys have prescribed these drops for? If you just had to guess real quick, what's your number?
Oh my gosh, I have no idea. I'm getting confounded with all the people I've done studies with too. That's a really
Yeah.
hard question to answer. I mean, at this point, in hundreds.
Wow.
Yeah, but I don't know, right? Like again, I've had experience with a lot of patients, which has helped quite a bit with our discussion here today.
Yeah, my answer is going to be 50 to 60-ish, somewhere in there. That's my estimate.
Mm-hmm. Awesome. I think mine's like 7, but I will definitely do more after this talk.
Well, hopefully you feel more comfortable with our tips and tricks here.
Yes, they were great. And speaking of being able to talk about more tips and tricks and more questions, or Assist we'll get to hear from shortly. And a big thank you for exhibiting at this event. So they have Closey. So if you guys stay tuned, we can ask more specific questions to Closey that maybe we weren't able to get to today, or if you just want to dig in a little bit further. So we'll get to hear from Dr. Derek Cunningham for the Woo You Mythbusters Live.